Good morning. This is Chair Artie Harris, and we're about to start the October 16th Commission meeting. May I have a roll call, please?
Chair Harris.
Here.
Commissioner Hedrick.
Here.
Commissioner Linden.
Chat.
Commissioner Linden.
Jim, you might have missed, he's not able to put on audio where he is, but he has confirmed he's here.
All right. When votes come around, is that going to be an issue? How is he going to vote?
In the
He's
chat.
listening and he
In the chat,
was
thank
going to
you.
put it in the chat.
Terrific, thank you. Vice Chair Shapiro.
Here.
Commissioner Giraldo.
Here.
Commissioner Washington.
Present.
Thank you. Commissioners Bartlett, Pedoeem, Dorner, and Bailey are absent today. We have quorum with 6 commissioners. Thank you.
Thank you, Mr. Adams. Do I have approval of the agenda this morning? There is one change. Would you go over it, please?
Yes, we are moving what was in the original agenda under item 1B, which is a resolution, to go now to 5D. We are also going to be front-loading all voting items to the beginning of the meeting, so things are going to be skipping around a little bit.
So do we have a motion for approval of the agenda?
So move, Mr. Chair. It's Commissioner Giraldo.
Second, this is James.
So he is moved by Commissioner Giraldo, second by Commissioner Hedrick.
Chair Harris.
Approved.
Commissioner Hedrick.
Approved.
Commissioner Linden in the chat. Commissioner Shapiro.
Vote aye.
Right. Commissioner Giraldo.
I vote yes.
Commissioner Washington.
I vote aye.
Thank you. That's 6-0.
Thank you so much. We're now is the approval of commission minutes of the open session September 18th, 2024. Do I have a motion for approval of these minutes?
Move approval, Commissioner Giraldo.
Second, Commissioner Hedrick.
Thank you. Chair Harris.
Approved.
Commissioner Hedrick.
Approved.
Commissioner Linden. Vice Chair Shapiro.
Vote aye.
Commissioner Giraldo.
Yes.
Commissioner Washington.
Abstain. Not present. I was not present.
That is 6 in favor, 1 abstention, 4 absent. Thank you.
Great. We'll go next to our voting item. It's resolution, it's 5D. It'll be Resolution 24-21, appointment of Bill Spencer. William Spencer is acting executive director. What I want to first say is that this is in relation to Asantha Chang Smith, who resigned at the end of September. We just want to thank her for her 5 years of dedicated service to the commission. So let's moving on to the resolution. Do I have a motion for approval to appoint William Spencer as acting executive director?
So moved, Mr. Chair.
Seconded, this is James.
Chair Harris.
Approved.
Commissioner Hedrick.
Aye.
Commissioner Linden. Commissioner Shapiro. Vice Chair Shapiro. Commissioner Giraldo.
Vote aye.
Commissioner Washington.
I vote aye.
6-0. Thank you.
Great. I think that ends all of our voting items.
On
We have one more.
5B.
Yeah, that's right. Excuse me. 5B is the budget transfer requests. We have Ms. Terry Charles presenting this morning. Welcome.
Good morning. Again, this is Terry Bacote Charles, Corporate Budget Director. I'm before you to ask for your approval to proceed with the annual transfer of the 5 funds non-departmental salary marker to the specific departments and units. As you will recall, you have as a body already favorably approved the negotiated agreements on July 17th and September 18th. This transfer totals $12,573,453. of which 7.2 million is accounted for in Prince George's and 5.1 million is in Montgomery County. And the transfer also includes a little over 275,000 to meet unanticipated increases in compensation related to approved legal settlements. With that, I thank you for your consideration.
If there are any questions or comments for the packet that Ms. Charles put there, or any questions from the board, if hearing none, do I have a motion for approval of the budget transfer request that Ms. Charles presented?
Move approval,
Move
Mr.
approval,
Chairman,
Mr. Chair.
Commissioner Washington.
Okay. Is there
Second, Commissioner Giraldo.
all right, Ms. Washington, motion, and Mr. Giraldo, second. All in favor?
Chair
Yes.
Harris,
Aye.
Commissioner Hedrick,
Aye.
Commissioner Linden. I haven't seen a recent one.
Somebody better text him or call him.
Is he dropped?
I'm on it.
Lana's on it.
Yes. That's the first three. We have 4 votes, so we're standing by for Commissioner Linden's 4th vote. This is for the budget transfer. Vice Chair Shapiro,
I vote aye.
Commissioner Giraldo,
I vote aye.
Commissioner Washington.
Vote aye.
6-0, thank you.
So now I feel we've gone over all our items that we have to have a vote on, so we'll, seeing none others, we'll go on to our general announcements. There are several here this morning. I just want to, the Breast Cancer Awareness Month, the National Pregnancy and Infancy Loss Awareness Month, the National AIDS Awareness Month, Hiring People with Disabilities Month, the National Domestic Violence Awareness Month, Italian American, German American, and Polish American Heritage Month. And I wanted to just a couple more here. One is I mentioned I put out before we had a lovely by-commission newsletter this past in October. I felt it was very well written, very informative. It really pushes both counties about one commission, so I really love the newsletter, and I thanks for all the communication folks on both Montgomery Montgomery and Prince George's for putting together that newsletter. I also want one more recognition is I want to recognize Andrea Rose, the Executive Director of Employment Retirement System, who is retiring as of November 1st. I want to recognize her 34 years with the commission. I wasn't here then, but I remember, I hear that she started as an analyst in ERS 34 years ago, so I thank you for all her dedicated years in the commission. And also like to welcome Jacqueline Harris, who will be the new Executive Director of ERS starting on November 1st. So let's go on to committee and board reports. The first one, these two are for information only, but the first one is Employment Retirement System Board of Trustees regular meeting minutes from September 3rd, 2024. They're in the packet this morning for information only, and the next is Audit Committee Activity Report for information only. The next we're going to is action and presentation items. This morning we have Renee Kinney here with presenting her Inspector General Annual Report. Welcome, Ms. Kinney.
Welcome. Thank you, Commissioner Harris, Commissioner Shapiro, all the commissioners. Renee Kenny, for the record, Inspector General. I'm here with my Deputy Inspector General, Mudupe Algundale. We're going to tag team on this presentation. It should be in your packet. And we'll just kind of hit the highlights. But I do want to ask if there's any specific questions on any of the audits and investigations, we'll be more than happy to answer them. But I would suggest that we go into closed session. That way we could have a real open discussion in case the conversation starts getting into sensitive personnel issues. So at the end of this, please let me know if we should schedule a closed session. So I am going to jump right to the highlight section in our report. This kind of summarizes what our team did last year. This is fiscal year 24. We did 13 performance audits, 3 limited investigations. We issued 46 audit recommendations. We taught 13 internal fraud courses throughout the commission. We completed 4 fraud, waste, and abuse investigations, 2 management advisories. We had 3 major audit findings, which I will discuss, and we also reviewed 18 recommendations during we completed 18 follow-up reviews. The next page, it talks about our services that we provide. And as I mentioned, we do performance audits, and those can be broken down into either a business process audit or a facility audit. We do information technology audits, fraud, waste, and abuse investigations, management advisories, follow-up reviews, and internal trainings. The next slide is just a nice org chart of my wonderful team. All this work is not just done by one person. We all work together, and I like to take this time to compliment my team if they're listening, especially Madupe. The next page talks about our governance. And both the Audit Committee and the Office of the Inspector General was established by statute. And I put the state statute numbers if you so wanted to look that up. But I did want to talk a little bit about the Audit Committee. They are so important to our office and the commission on a whole. They provide our office with guidance. They receive copies of all of our audit reports. They meet with me and Madupe quarterly. They meet with the external auditor. So it's a really important committee. It's made up of 4 voting members and 1 non-voting member. The non-voting member is the commission chair. So right now, Chair Harris is on the audit committee, but for this report, it was Chair Shapiro. So the committee's made up of 2 commissioners, 1 from each county. Dorothy Bailey, Commissioner Bailey, represents Prince George's County, and she is the chair of the audit committee. Commissioner Mitra Peterdome represents Montgomery County. We have 2 public members, but I really want to take an opportunity to thank them because all the work they do is free of charge. There's Mr. Ben Williams. He's the Director of Internal Audit for the Association of Medical Colleges. He has over 25 years' experience in audit. He's a certified internal auditor, a certified fraud examiner, so he brings a wealth of guidance to our team. In addition, there's Ms. Erin White, and she's a CPA. She has all the accounting knowledge. She is the Director of Finance for Frederick County. So Ms. White's on her 2nd term, Mr. Williams actually on his 4th term. So they've been, just want to take a shout out to them. We do follow audit standards. That's a little box to the left for our reports. And we are subject to a peer review. And the peer review teams are made up of external government auditors, and they come and it's a thorough audit. They look at our work papers, they look at our processes, they look at our CPEs, and they opine on whether we are operating effectively. So we've always passed our peer reviews. Each year, we publish an annual work plan. This is when I want to thank all the commission leadership and managers. Each spring, we reach out to them, either one-on-one or in surveys or various fashion, sometimes interviews, and we can ask them, how can we be of service? What's keeping you up at night? Because we have to put together an annual work plan, and that work plan is then presented to the audit committee, and it's voted on and approved. So the fiscal year '24 work plan included, and we're showing this graph in percentage of total hours. Follow-ups, about 9% of our time, limited investigations, 8%, fraud, waste, and abuse, 11%, performance audits, about 60%, and management advisories, about 12%. The next slide's the audit process. I'll skip through that, but if you have any questions on that, you could reach out to me or anyone on my team. The next slide talks about performance audits. So in fiscal '24, we completed 13 performance audits. 6 were business process audits and 7 were facility audits. And there's the list of the business process audits. We looked at the manual adjustment of leave accruals, identity and access management, commission workplace safety and OSHA compliance, purchase card program, e-discovery, and we looked at the controlled assets in the northern and southern region maintenance yards. That in itself is a pretty long list if given the size of our office from the slide a little bit earlier. We also do facility audits, and that's when we go into a facility and we look at all of their business operations, petty cash, purchase card, vehicle use, travel, you name it. If they're doing it in the facility, we're taking a peek at it. So we, and that includes the list of the facilities we got to in fiscal '24. Our performance audits typically include recommendations, which require management to respond. Most of the time, they concur, and they provide us with a statement of what they're going to do to mitigate or resolve the audit recommendation. We are then required, and this is part of the standards that's looked at during the peer review, we have to go back and complete a follow-up review and report on whether the audit recommendations were resolved or mitigated. So we did 18 follow-up reviews, and it resolved 38 out of 39 recommendations. The next page talks about fraud, waste, and abuse investigation. Again, we never know when we're putting together our work plan how many fraud, waste, and abuse investigations we're going to have to look at, but they seem to be getting more frequent. Last fiscal year, fiscal '24, we did 4. There was 1 that had to do with excessive event purchases, 2 separate investigations on a conflict of interest with a commission employee and a vendor, and there was 1 alleged time card fraud. And again, we can get into the details more if you would like in closed session. Limited investigations is almost exactly what they sound like. We do get a lot of tips on our hotline, or people might call us, or we get anonymous letters dropped off in our office, and we will look, and we always do some due diligence, and we might, it's a professional judgment, but we might make a determination that a full fraud, waste, and abuse investigation is not warranted, so we will do a limited investigation, and we completed 3 limited investigations last year: alleged unauthorized network access, some alleged travel approval irregularities, and we were asked to look at a business checking account reconciliation. Management advisories, these are considered non-audit services, and these are, you can maybe look at these as consulting services, and sometimes management will ask us if we will look into something and just give our professional opinion. So last fiscal year, we did 2 management advisories. We were asked to assess the Commission's administrative project charge process from notification of the charge during the budget planning to the final disbursement of funds. So we did look at that. We put out a report, and the report was shared with County Council. And we also, and this is very brief because we're in open session, we did look at some possible security threats. And again, I'm not going to talk about that right here in open session, but able to elaborate. The next page talks about our major and pervasive audit concerns. When we issue a performance audit, there's one section called major audit concerns. And we know sometimes people on the distribution of the audit reports might not have the time that day that it comes out to read the whole report. So that's why that page is there, so they can flip to it. And that if there's something on that major audit concern page, that means we hope they probably would read it and take immediate action. And there just seemed to be a theme in our major audit concerns this past year, and it had to do with insufficient oversight and monitoring. For example, if you look at the pervasive audit concerns, I listed the top 4 pervasive audit concerns. So these are recommendations across all audit reports. The first was management review and oversight. Project charges, that was kind of a one-off because it was a special management advisory, so we really don't want to count that one too much. But then there was a significant number of recommendations on system access and then controlled assets. Last year, controlled assets was a major audit concern for fiscal year 23. We noticed a significant improvement this year, and I do want to thank everyone, especially the teams working out in the maintenance yards who have a lot of controlled assets. We've seen definite improvements, but it still keeps popping up as an audit finding. So that's it of the report. The next pages are the appendices, and they list all of the reports and investigations that I just discussed. So Appendix A, it lists all of our performance. It has the audit status. It talks about each of the recommendations and the details. So I'm not going to read through that this morning, but that is there. That's Appendix A. It's quite a few pages long. And then, let me see here, we jump to Appendix B. That's a summary of our fraud, waste, and abuse investigations. Again, it's very high level. It talks about the excessive event purchases, there's an alleged conflict of interest, the alleged time card fraud, and the second alleged conflict of interest. Again, happy to discuss in detail later. Appendix C's are limited investigations. So that is it of the formal presentation. Dupe and I are available to answer any general questions now, or if there's a specific request to go into closed session at the end of the commission meeting, please let Chair Harris know now.
Thank you so much. I just wanted to first say I really appreciate all of your hard work. Ms. Kinney and Ms. Dupe, your organization is so important for a company like ours, for the commission like ours. So I appreciate your hard work. I also want to thank the audit committee for all the hard work that they do in putting this. So this is so important. So thank you so much. I'll ask the commissioners if they have any general questions, but I just wanted to say thank you. I really appreciate your work. Okay?
You're welcome.
Yeah. So the commissioners, do you have any general questions that you'd like to ask? None being seen or heard. Thank you so much. I really appreciate it.
Chair Harris?
Yes.
Just, I want to, I don't have any specific questions, but I just want to associate myself with your remarks. I think that the work that you all do is just so critical to the health of the organization. I really appreciate the sort of way you all can switch roles. You come in sometimes and around a waste, fraud, and abuse issue, and you're diligent and delicate about it, and then you can come right back around with a management advisory and help us think about how to do our jobs better in all sorts of ways. So it's an impressive amount of flexibility that you show, and you really are incredible value add. So I would just associate myself with Chair Harris's remarks as well.
Thank you, sir.
Yeah, thank you so much. So let's go to our next item, which is the item 5C, which is the GLP #1 prescription approval process. And Todd Allen and Jennifer McDonald are going to present today. This was a follow-up to some questions that the commission had at our last meeting. So welcome, Mr. Allen and Ms. McDonald.
Good morning, Commissioners. I'm Todd Allen, Director of Human Resources, and I have with me Cynthia Henderson, Benefit Specialist 3, and Jennifer McDonald, our benefits manager. They and the full benefits team do a great job across the board on our health and benefits program. During the September 18th commission meeting, Jennifer McDonald presented that we're getting a 21.7% increase in our prescription drug premiums, which would have been higher if we did not implement some measures relating to GLP-1 drugs October 1, 2024, since utilization and claims for these drugs increased by 118% from 2023 to 2024. We did use 1.5 million in excess reserves to bring costs down to our employees. So employee costs will go up 11.7% and not 21.7% effective January 1, 2025. Open enrollment period starts Monday. Now, commissioners asked Jennifer and her team to provide additional information on GLP-1 drugs formerly titled glucagon like peptide 1 drugs under the agency's prescription drug plan and the measures put in place effective October 1, 2024 to address the rise in GLP-1 utilization and claims costs. We also will be bidding the Caremark program spring 2025 to explore the best program for M-NCPPC employees, retirees, and dependents, and all options related to GLP-1 drugs will be explored during that upcoming bid process as well. So Cynthia Harrison will present Caremark Smart Edit and Utilization Management Weight Loss Bundle programs, and then Jennifer McDonald, Cynthia, and I will be available to answer any questions. I'll turn it over to Cynthia Henderson first. Thank you.
Okay, I'm going to share my screen with the presentation in your packets. Okay, does everyone see the screen?
Yes.
Okay. Okay. I'm going to start with the third bullet. What are GLP-1s? They're a class of approved FDA drugs indicated for the treatment of either type 2 diabetes or obesity. What do? They increase insulin release, delay your digestion, and decrease your appetite. Mainly, they tell your brain that you're full, so you don't eat as much. And they've been proven to help reduce your body weight up to 21%. GLP-1s are also associated with common gastrointestinal side effects, such as nausea, vomiting, stomach pain, diarrhea, and constipation, but they tend to resolve in about 4 weeks. Let's look at the costs for the GLP-1 drugs. They average, whether diabetes or weight loss, about $1,500 per month or $18,000 per year. How much is the copay for employees? For generic drugs, $8 per prescription. Preferred brand, $16. Now, the only one that has a generic drug so far is under the diabetic category. There's a generic for Victorza. And under the weight loss, the GLP-1s, they're only preferred brands so far, so those members are paying $16 per prescription. There are no generics approved by the FDA for those yet. And
Cynthia, can you scroll down? I don't think we're seeing the
I'm sorry. Here.
There we go. Thanks.
Okay. And we're not expecting any generics, say for Wegovy until 2030 and for 2031, I'm sorry, and for Ozempic in 2030 because their patents have not expired yet. Here are some of the GLP-1s covered our advanced formulary, the preferred brands. For diabetics, Ozempic, Rybelsus, Trulicity, Victoza, and that's the liraglutide. That's the generic for Victoza. That was approved in June of this year. For weight loss, Wegovy, Saxenda, and Zepbound. Let's look at the utilization and cost for GLP-1s in 2023 versus 2024. The main increase, and Todd already touched on this, was under the anti-obesity GLP-1s. Their claims increased 118%.
I'm sorry, Ms. Henderson, we're getting some, or at least I'm getting some playback when you speak.
I think it's coming from Jennifer. You might want to mute.
Okay.
you. Okay, and under the anti-obesity drugs, that there was that 118% increase in claims, and that also represented a 76% increase in the total gross costs for those anti-obesity GLP-1s. Now going to the two measures that we put in place effective October 1st, 2024, the Smart Edit and the Utilization Management Bundle. Basically, for both, for the GLP-1s for diabetes and for weight loss, prior to October 1st, the member would just go to the pharmacy with their prescription from the doctor and it would be filled with no checks and balances. Under the Smart Edit plan, that's for the diabetic drugs, the patient would now go to the pharmacy and present their prescription, and then it's run by the Smart Edits. They look back in the patient's history for 2 years to see if they have a code for diabetes, diagnosis code for diabetes, or if they've been using a diabetic drug. If so, the claim will pay immediately. If not, the doctor will have to submit a prior authorization for that drug. If the claim is rejected for a prior authorization, the claim will still reject, and it will continue to reject. And for pre-diabetics, if they've been using a diabetic drug, then they will also be approved. Now, under the UM bundle or utilization management weight loss bundle, that's for the obesity GLP-1s, there's a hard stop. When the member goes to the pharmacy and presents a prescription, it's automatically going to be rejected for a prior authorization. So the doctor must submit a prior authorization. If the criteria is met under that prior authorization, the claim will pay. But if not, it will be denied. Here's a sample of some of the criteria under the prior authorizations. The member must have a body mass index of 30 or higher, or a body mass index of 27 or higher, and must also have one or more weight-related conditions such as diabetes, high blood pressure, or high cholesterol. The patient must participate in a comprehensive weight management program that encourages behavior modification. They have to reduce their caloric intake and also increase their physical activity with continuing follow-up for at least 3 months prior to using the medication. Another criteria, patient must use the medication in combination with lifestyle changes and also reduce calorie diet intake. Now we're implementing these measures under the diabetes so that they're not used off-label for weight loss, and to avoid disruption for those patients with a confirmed history of diabetes so they can still get their medication with no problem. And that's under the Smart Edit. Under the Utilization Management Weight Loss Bundle, this ensures that the GLP-1s used for weight loss are clinically appropriate and cost-effective. Now, we hope to reduce our expenses, but our main goal is to increase the health of our population, to make sure they have a healthier outcome using these drugs. Does anyone have any questions? Todd, did you have anything to add, or Jennifer?
I think we can go straight to questions. Thank you. I see a hand up.
Yeah, Commissioner Hedrick, you have your hand up.
Yeah, I realize we've already instituted these policies and this Smart Edit and stuff, but I really don't like this. I don't like putting hurdles in between people's ability to access diabetic drugs, particularly things like GLP-1s that have been, have shown to have a lot of benefits for both type 1 and type 2 diabetes. I think it is anyone that I think has dealt with the American healthcare system knows that accessing a previous diagnosis when you move doctors, when you move areas, when you move geographically, accessing those records is difficult. And I think it's a little bit optimistic to assume that we're going to be able, particularly when someone comes on board with us, to be able to have that information ready. And you can't take these drugs, not take these drugs for 2 months while you wait for paperwork and then go back on them and expect them to continue to work. That's really dangerous for, a variety of your measures for diabetes. I, I don't like either of these. I don't like the smart edits, and I don't like the smart edit, and I don't like the weight loss bundling. And I don't think that putting hurdles in between people getting access to drugs that they've been prescribed is particularly helpful or has anything to do with leading to improved patient health outcomes for the employees, retirees, and their dependents getting healthier. I think that sentence really, I don't think, flows from any of the information that's in here. And I really don't like the barriers being put up to get prescriptions that folks need. There's a reason the GLP-1s have been prescribed. And I don't like adding in the necessity of a bunch of behavioral modification outcomes that the research and background information on is not particularly effective. These drugs are effective because the drugs are effective, not because of nonsense with you're learning about, people know about calories, people know what's healthy to eat. Like, that's unnecessary. And I think it's counterproductive and also only puts a hurdle between people getting drugs that they've been prescribed by their doctor and ours. I really don't like this whole policy, and I think we should roll it back. And I'd like to have a conversation about that. I don't think this is a good idea. I don't think it's good for our employees across the commission, and I just don't like putting barriers in there to this. I understand the cost issues, but if our concern is really improved patient health outcomes for our employees, retirees, and their dependents, as we say, then why are we putting unnecessary barriers to people accessing it, particularly people that are going to be coming on, as they're going to be coming on to staff and having medical record access issues? I think this is a bad policy. I don't like it at all.
Okay.
And I don't think we should do it.
Yeah. So thank you. I appreciate your opinion on this, but I have the question: if you go back to, not you per se, but the requirements here, is this something from our that we make these requirements, or these are well, where did these requirements come from? They're just out of curiosity.
So our benefits consultant recommended it, as well as Caremark recommended it. I guess what they were saying is there were no checks and balances before. For most prescription drugs, there's other checks and balances built in, various sorts. So if somebody has acid reflux disease and they're prescribed a brand name, they would pay more for the brand name, but they might have to take a generic and try generic first, like a omeprazole, even though something else is prescribed, and there's different formularies. We have done other programs such as advanced formularies and things like that try to add more clinical management. And so this was recommended for our particular program, and it is quite commonly used.
Okay. So do we have requirements like this, restrictions like this on other drugs that out there that the commission employees have access to? I mean,
Jennifer, do you want to speak about that a little bit?
Yes, so this is not the only drug where we have prior authorizations. There are several drugs that's on our formulary that require prior authorization. I don't know off the top of my head, but this is not something new to our prescription plan. We have prior authorizations for other types of drugs. Primarily, again, is to make sure that the drug is being accurately prescribed. Now, in terms of Commissioner Hedrick, you talked about new employees coming on board. The prior authorization is done by telephone. You call the doctor. It happens within a couple of days. We're not talking about months.
It happens a couple of days if you have access to your prior medical records and can provide them. It doesn't happen if you have trouble getting your medical records if you've moved.
It's
having
simply...
had a lot of experience with the American healthcare system, I think it's very overly optimistic that this is something that's just a phone call away.
Well, it is because the prescription is written by a doctor, and the doctor, it's a telephone call to the doctor.
Well, what I'm seeing here with this is that you have to have a previous claims history or diabetic diagnosis within the last 2 years, essentially. If you have moved and have to request medical records from another doctor or a prior doctor, and you've moved here from somewhere else, getting those medical records can be incredibly difficult, and it can be incredibly difficult to maintain those. There's a it looks nice on paper aspect, and there's a practical aspect to it, and the other question that I can see that what we have here is an increase in the prescription of these drugs, both for diabetes and for weight loss, and I understand that because there's a very large turnover in the prescription from previous diabetic drugs to the GLP-1s because they tend to be pretty effective. But what I don't like with the prior authorization for the smart edits is I think that we're being overly optimistic by how easy people can access their own medical records, particularly if they're moving across the country. And why do I want to put a hurdle between somebody who has a prescription from their doctor for what they need? And this is an issue that you see all the time with prescriptions for psychiatric drugs, anything from ADHD to bipolar disorder and things like that. And these drugs are analogous in that missing doses over time can really affect your health in really bad ways. I just don't. I understand it's expensive, but it's expensive for a reason that they don't have generics at this point for most of these drugs. Do we have this level of prior authorization for other drugs that don't have generic options?
Yeah. So why don't we do this?
We do.
Yeah. So why don't we do this? Why don't we do this? Great questions. And what I'd like to, if you could, staff, come back with some questions, answers to what are the other types for our next meeting, or just send it out. And also, Commissioner Hedrick, we will monitor this, right? And I understand your questions, and we will monitor this, and I don't know if staff ever gets feedback through the, and are there systems where you can, if you're denied, is there like a process that you can go through?
Yes.
Yeah,
Yes.
And so I just want to make sure, this is just not like if someone gets denied because of this, there's not a process they can go back to. And then also, this is the first year, I think this may be the second year where these drugs this is coming up and the costs are going up. We want people to have access if they really need them. And so one of the options is just to test this for another year. This came up, and we wanted people to be healthy. We want to, because, it may be a little costly here, but if they're, overall their health improves, and it's better for them in the long run. So, but if you can come back with, on other drugs, are there limits like this? And then, but I would suggest that here's a possibility that we go another year and see if there, where this all shakes out, if we get grievances or we get things, and then, but we do want to make it as easy as possible. But we also understand what the care.
May I?
Yes.
Yeah.
Okay.
If I could say one thing, I think we'll add too that we'd like to get back to you with details about the appeal process.
This call is being transcribed.
So I would just add that
this call is being recorded.
To provide that additional information as well about that process. Thanks. James?
Yeah. In reference to that, Commissioner Chair Harris, can I request two things from staff if we're going to go this route?
Yep, certainly.
The first thing I would like to request for staff is what other drugs without available generics do we treat like this, and what are the processes for accessing those drugs, with the PA process. The second one is, how are we going to measure the effectiveness within a year? Because currently, given what we've had in this memo and the previous one, the way that we're going to measure it is by how much our costs are reduced, which I think is a really bad way to measure it. So in addition to having, if we're going to come back with a report on the effectiveness of this, I not only, as Chair Harris mentioned, want to include the number of requests, number of requests for, I don't know what you'd call it, an adjudication of a rejection or something like that. I want to know about people that have appealed. I want this to be measured in some other way merely than the cost to us, because if we are really saying that we want the health of our employees, retirees, and their dependents first, then we need to measure the health and whatnot of our employees, retirees, etc. So I want the measurement to be something related to actual health claims and the actual health of our employees somehow, and not just the monetary portion of it. And I do want more information then about the appeals process, as you mentioned. And I basically want to make sure and ensure that we are not preventing, particularly for the diabetic prescriptions, that we're not preventing people from accessing these drugs.
Great. No, duly noted.
Yes, we can certainly do that.
Yep. Thank you for those great comments. Next, we have Vice Chair Shapiro. With you.
Sorry, I couldn't get to my microphone. Yeah, I just want to thank the team too for diving into this. It's complicated and it's all happening in real time, and we're seeing it in jurisdictions all around the country. And I know you all are doing your best to manage this in the way that's most effective for the commission. And I really associate myself with Commissioner Hedrick's remarks. I think that let's make sure that we're looking at this for the right reasons. I trust Gerald's intentions around this, but I think, hear loud and clear from Commissioner Hedrick, and I agree that we want to put as little barriers in front of people as possible. So, Commissioner, thank you for your remarks on this, and of course to Todd and Jennifer, thank you for everything you're doing on this. Really appreciate it.
Thank you, Peter. I also want to slip in one suggestion. I know there's more hands up, but I wanted to say what we receive from Caremark is only aggregated data, but we do get that quarterly. So I will offer a suggestion that we not wait a year like has been requested by James and Peter. So, for example, in February, we would receive quarterly data for October, November, December. It's all aggregated data, so we would not know individual specific. However, we also would simultaneously have some information I think could be helpful as situations occur and are reported to us, as well as other data we can request, appeals, things like that. So I would suggest, a return to you in February as one opportunity that would be more timely, as well as other feedback earlier than that. So I would like to offer that right away, that we would have at least some early data that could be very helpful. And I appreciate the request for it to be, this is not just about cost savings. We wanted this to be a much more thorough, holistic review. And I think February, we would have data that I would like to offer up the aggregated data. So I just wanted to slip that in. Please continue with questions.
Yeah, periodic reporting would be great. So next, Ms. Washington.
Thank you, Mr. Chairman, and thank the team for providing us with the information for what has turned into a very thoughtful discussion. I'd like to strongly associate myself with Commissioner Hedrick's comments. And I speak just from personal experience in trying to help my mother navigate access to her prescriptions and drugs, and what always seems like and sounds like and looks like on paper a great process, it never translates into that. And it's not an economic issue for her in as much as it is an access issue. So that's number one. Number two, in terms of coming back and/or the reporting that's provided, I wonder if there's any data on populations served, because it's one thing to look at various drugs and what the protocols are, but depending on the population served, the impact can be significantly higher with regards to the risk that we may be assuming relative to that. And I'm thinking specifically as it relates to diabetes and the disproportionate impact that it has on certain populations. So I just wanted to offer that as well. So thank you.
Yeah, thank you for your observations and your requests. So we'll go on to Commissioner Giraldo.
Yes, I don't think there should be any restriction with regards to diabetics that are prescribed this medication. I am supportive of if employees want to have the GL1 and it's purely for weight loss reasons, I think there needs to be some behavior modifications. Diabetes is one thing, or diabetics, but if someone simply wants it to assist them in their loss of weight, that behavior modification is important, because from what I understand, and I might be wrong, but I understand that these drugs, once you start taking them, even for just weight loss, you have to take them for the rest of your life. Otherwise, you go right back up. And so at that point, that costs. And so what I proposed last time we discussed it, I don't mind us providing it, but perhaps a care mark to say that those individuals who want to have the drug for weight loss, in addition to the medication, maybe there could be a higher copay for them, which would reduce our costs.
Yep. So
That's it, Mr. Chair.
Yeah, thank you for that. So I think this is all about getting more information as we requested, and as Ms. Washington said, this is a very thoughtful discussion, and staff, and thanks, as Mr. Vice Chair Shapiro said, staff's done a lot of hard work, and we're going to digest that, a lot of that, and get some more information, and so we can we'll be ready for next year about our limits, and if we make, I don't know if you can make some changes midstream, but we'll have enough data, and these were all good questions. So if there are no other questions or comments on this, we'll move on, but thank you, all of you, for your comments and questions, okay? So
I'll just echo that and
Yes,
say
thank you.
thank you for the insightful, thoughtful comments, and we will be providing more information. Thank you.
Okay,
I
great.
echo that as well. I appreciate all the comments. Thank you.
All right, thank you so
Thank
much.
you.
And we're going on to officers' reports. For information only, they're in the packet. There is the late evaluation quarterly report. There's a Secretary Treasurer's report on the 115 Trust OPEB annual report presentation, and then there's the General Counsel's litigation reports, which we're so happy to get on their proposed schedule. So thank you for that. And then I wanted to make one last comment. So Peter and I went to the Commission's Employee Fall Festival Fresh Fish Fry yesterday. That's a mouthful to say that, but it was wonderful as a getting together of the Central Administration Services staff, and it's always good to get together and for people to meet one another. You see each other in the hallways, but to just have time to talk. It was great food, great little tchotchkes there, and they even had a contest with the best Halloween costume. So it was a very fun event. So thank you for having that. And we always keep pushing. We're one commission, and we want to enjoy and learn from each other. We have such a depth of talent here. It's really important that we get together periodically and learn from each other and communicate. So if there's nothing else there, I would recommend that we end the meeting today, and I really appreciate working with all of you. Mr. Hedrick, you have your hand up.
Yeah, sorry to A, interrupt again, and B, do it right as you're trying to ask for things. I just want to make sure, if I had a couple of questions on the on one of the pending litigation, which is absolutely not necessary to do an open to do in an open session, I just have just some FYI, is it acceptable to contact Deborah and our general counsel offline for a couple of questions and
definitely,
not do it here?
Definitely.
Yes, absolutely.
All right, thank you, Deb. Appreciate you.
Yep, so if there are no other comments or questions, thank you for the meeting, and this concludes our commission meeting of October 16th, 2024. Thank you, and have a great day.